having me again, and thanks to all the sponsors and of course all you guys, because without you coming, there's no point of having a conference, hey? So my passion is mental health. I've worked in mental health for 36 years, so that makes me feel really old, and I've worked over all aspects of mental health. I am credentialed, which means I can work privately, and I have been working in a neurodiversity clinic recently. This is my offset partner, Susie. So Susie is a ED CNC, and she's very important to my role, especially as the co-responder. So does anybody know what the co-responder is? QAS mental health co-responder, does anybody know that? Okay, so my role is that I am a CNC. I go out with the ambulance and with the police with the idea of preventing bringing people in, so ED avoidance. And I think we're keeping out 66% at the moment, just doing those mental health assessments out in the community, which is great. And especially when we discuss neurodiversity. So is anybody an expert in neurodiversity? Is that a pat on somebody's shoulder? Oh, okay. And maybe if I can have a hands up for, maybe we'll look at who are the nurses in the room. Yeah, brilliant, because we are wonderful. What about the doctors in the room? Great. Ambulance? Yep, wonderful. Anybody else? Any allied health? Any mental health practitioners? No, wonderful. Okay, this isn't a pathophysiology discussion. I'm trying to just give you a brief background on neurodiversity and mainly concentrating on communication skills, which are pivotal when we work with this clientele. Do people feel confident working in neurodiversity or with neurodiverse patients? Wonderful, Mark. So if I have any tricky questions, we'll direct them to Mark. Okay, so where is the clicker? And if I drop it, it's because my hand is not functioning all that well. Okay, so I just thought I'd give you a snapshot, and I'll ask Susie maybe to talk a bit about this, because this is for Gold Coast, which I think Mark mentioned the other day. We are the busiest ED.
Okay, yes, we are very busy most of the time. This is the snapshot of 2024 presentations. Last year, 127,600 presentations to ED. Of those, there was over 30,000 children, because we have a designated children's ED within the ED. The busiest months really are all over the shop. We have January, March, April, May and July, and they're pretty much standardised presentations every month. You can see all the Cat 1, 2, 3, 4, 5 triages, and these clients we're talking about fit into most of those categories at certain times, depending on how they're triaged as they present.
Okay, so a brief introduction to what neurodiversity is. So neurodiversity is quite broad. So it includes autism, ADHD, dyslexia. Oh, that's quite bright, isn't it? And it's really important to understand the concept, because it's really essential for how we manage our patients. In this presentation, we'll try to look at best practices, considerations to ensure effective communication and treatment for the neurodiverse individuals in ED settings. It's a bit of a busy slide, hey? So what we do know about neurodiversity is it overlaps. So can everybody see that slide clearly? Yep. Does it look confusing? Yep, absolutely. So everything overlaps. So the key to doing a good assessment is trying to understand how things overlap and pulling apart each different component and looking at how we assess that. So when we get into assessment, and again, I'm not going to do a lot on that because that's not our role as emergency clinicians, but it's really important to try and tell the difference. Okay, so neurodiversity was coined by Judy Singer, I think it was 1990s. She describes people with different characteristics, behaviours of neurodevelopmental conditions alongside the neurotypical majority in a non-prejudiced way, which is important. Having knowledge, it moves the focus from impairments towards people's positives and their abilities. And it's thought up to 15% of the population are neurodiverse. And I bet you there's people in the audience that are probably neurodiverse, and I'm not going to ask you to put up your hands. But I think the field that we work in, it attracts the neurodiverse community, and we're very good at what we do. So if we look at a brief definition on ADHD, so it's complex, multiple causes. It's not a social cause, but social stressors do impact. If we look at the effects of executive functioning, does everybody know executive functioning? You would have heard that term? Yeah. So it's self-awareness, inhibition, verbal working memory, non-verbal, emotional regulation, planning and problem solving. Researchers agree that EF doesn't occur all at once. It has stages. The first three, which is self-awareness, self-restraint, and then visual imagery. Is that right? Yep. All occur together, and then of course you've got within the 5 years, and self-speech then develops. The remaining functions, which are self-motivation, self-directed emotion, problem-solving, planning, and forms of self-play, they derive when we take new information. The new information goes in, and we try and conceptualise it in our brain. And if the early EF are impaired, later ones will be as well. Do you agree, Mark? So EF is harder to identify as we get older. A lot of when I was working in private practice, we really concentrated on new assessments for those people that had fallen between the cracks. And it's definitely a lot difficult as we get older to identify what it is. So there's 7 core EFs that use together to form the dimensions. So we've got our self-restraint and regulation, time management, self-organisation, problem solving, self-motivation, and emotional self-control. Okay, facts around time management. Who's good at time management? Any hands up? Susie's great at time management, I do admit that. So young children only think about the present. Okay, and this is important when we're assessing to have some understanding about this. Early primary school, think 12 hours ahead. Later primary extends to 1 to 2 days. Adolescents, 3 to 7 days. University students, 1 to 3 weeks ahead. In our 30s, 2 to 3 months ahead. And ADHD, 30 to 40% delay in time management and ability to plan. And adult ADHD is the most severe with time management. I'll put my hand up, I'm awful at time management. And I'm neurodiverse, I'm not ashamed to acknowledge that. Has anybody heard of the term scaffolding, externalising? So I say it's more about putting structures around a person to help them cope. So people with ADHD must create these structures outside of themselves to manage what our internal structures aren't doing. Something that's crucial to work alongside the treatment, and most people with ADHD may subconsciously do this to manage. And I know myself, I've developed many skills over my years that have helped me manage without even knowing that I've done that. And the assessment of ADHD, it needs a thorough assessment. Sometimes I get really, and I don't want to diverse too much, really cross when people get a one-hour session with a psychiatrist and come away with a diagnosis of neurodiversity. It takes a lot more than that, especially with adults, to diagnose. It's important to get that thorough history, developmental history, academic history, if we can, including family. I feel that's really important. Including the partners in the assessment, what do they see? Mark's smiling there. How do they see the deficits and how does it affect the relationship? Okay, we have other tools that we use like the TOVA, and that's a specialist tool. And early identification can prevent diagnosis as ODD and conduct disorder. So I think Richard Barclay in the States is a bit of a guru on neurodiversity. He will really preach that the earlier we diagnose, we can actually prevent people being misdiagnosed as having oppositional defiant disorder and conduct disorder. And of course, males and females present completely different. There is some similarities, but a female will be more about rejection sensitivity, people pleasing, whereas males might have more of that hyperactivity, inattention. And it's important to know the difference, because often when we get to the different diagnoses, you will see how people can be misdiagnosed. Oh, drop me clicker. So in my assessment, if I'm out there on the road and I've been asked to come to somebody that I think is neurodiverse, as well as doing my full mental health assessment, I'll break down my assessment around neurodiversity. So first I'll look at EF. So I'll start to get an understanding what the concerns are around EF. If there's no concerns, then then you're thinking, oh, well, maybe this person isn't neurodiverse. I break it down to emotional. Everybody with neurodiversity will have emotional symptoms. That could be anxiety, it could be mood. Most people with neurodiversity do have anxiety, and there is a mood component to that. Behaviour, that's the one thing that people always will mention when we look at ADHD. They always focus on the behaviour. It might be not taking turns, it might be yelling out, it might be impulsively interrupting people. And then I'll always look at if there's ADHD, I'm searching for some ASD. Because in that first really, confusing slide, we can see that it overlaps. So that's important for me to understand. And of course, any learning difficulties. So misdiagnosis. Lots of people can be misdiagnosed if that assessment isn't done accurately. For example, BPD, everybody knows BPD, borderline personality disorder. It really frustrates me how many people can get labelled with that when it is actually neurodiversity, especially in females, because that label sticks. Depression, anxiety, however, these symptoms may be due to the impact. And also of note, if there's a diagnosis of mood or anxiety, I always say we should treat that first, have it 30% better before we start any treatment for the neurodiversity or ADHD. Addiction. In my clinic where I worked, we always said if somebody had an addiction issue, we wouldn't put them on stimulants. That would just be a bit silly. So we'd try and treat the addiction. But we do also know that people with neurodiversity often, if they're not treated early, will lead to risk-taking behaviour, because that's a big dopamine hit, and especially using substances, you get that big whack of dopamine. And if psychotic, you should never recommend stimulant medication, and they should be immediately ceased. Sounds a bit stupid if somebody was psychotic and we just treated them and then put it back on to the one thing that makes them psychotic. So comorbidities. 90% of children and 85% of adults are diagnosed with at least one other psychiatric condition. And around 50% of children with ADHD have at least two coexisting conditions. Susie, do you want to write on the whiteboard? I'm going to ask you guys to try and yell out some of those other diagnoses that may be present. Hands up. Anybody? Mark? Anxiety? Absolutely, anxiety is huge. Anybody else? Dyslexia. Yep, dyslexia, absolutely. Actually, when I re-watch my talks, it's a bit of a joke in my family, because I always say it should be a drinking game. Every time I say absolutely, people should have to scull a drink and you would be very drunk. So I'm trying not to say that frequently. ASD? Yep. So I didn't say absolutely, so yeah. B? DCD? Yep, do you want to let the crowd know what you mean by DCD? Dyspraxia. Yep. Yep. I think you had one, no? Hyperactivity. Yep. Do you want me to yell out a few? OCD. That's a really good one. And as I said before, if you look at Russell Barclay's research and what he talks about is if we treat early enough, we can actually prevent people being labelled with OCD, oppositional defiant, and conduct disorders. I'll add a few. BPAD. BPD, or now as we commonly say, EUPD. Anybody else?
What's that?
EUPD, emotionally unstable personality disorder. Very similar to borderline. It's more the common phrase at the moment than BPD. Just it's the same, just confuses people. Because in order to have a diagnosis really of BPD or EUPD, there needs to be some trauma really in childhood. So if you don't have that trauma, then how can you really have a true diagnosis of BPD? And especially when we look at people with rejection sensitivity disorder, which sits a lot with females with ADHD, it really mirrors BPD. I'll put you out of your misery and flick it. Absolutely, yes. Alice Danlos? Have a drink, did you say, Mark? Oh, I did, sorry. We should make that the game for the today. It would lead you well into the closing party. So every time I say absolutely, a bee has to have a drink. Sorry, Quentin, if I get them all drunk beforehand. 20 minutes left. Okay. So you can just read a few of those. Yep. So that can often happen, but also that happens with, I gave a talk in Bali around trauma and the effect of trauma on the body, which does put us at more risk of physical diagnoses later on in life because it affects our hippocampus, our amygdala, yeah? So we need to then, I will come to a slide that is confusing as well, but it looks at trauma and neurodiversity. Okay, so if we look at them, this is a bit busy, so I do apologise. I did try and cut it down. If we look at the behavioural challenges, so children with ADHD frequently struggle with tasks that require sustained attention. They might seem mundane or uninteresting to them. As a result, they will avoid or resist engaging, and it can lead to frustration and refusal to comply. I can't tell you how many times I've been called out to do a mental health assessment because it's more of a behavioural. The child has lost the plot, they've acted out, and then an ambulance has been called because they've said they're suicidal. They're not really suicidal, it's more out of frustration and anger. Impulsivity and emotional regulation, so it impairs a child's ability to regulate their impulses and emotions effectively, and they may act out in their immediate feelings. They don't have ability to control those feelings. So until we learn that scaffolding or externalising, we need to teach them how to do that. Yeah? Oh, I've lost this thing, Quentin. Sorry, slight error with the technology. I might just say absolutely just for the sake of saying it. So everybody needs to drink. Okay, challenges. So the EF challenges. It refers to a set of cognitive skills responsible for tasks like planning, organising, initiating tasks, and problem solving. So children with ADHD often lack the EF skills, which can hinder their ability to follow through with tasks, transitions between activity and complete assignments. Also, like I'm procrastinating over a uni assignment at the moment, so not a child, but I fit that model right now. Sensory overload. Children with ADHD may also be more sensitive to sensory stimulation, such as sounds, lights, textures. I went into a shop in Tokyo and oh my God, it was sensory overload. On every level there was a different music playing. I was like, what the hell is happening to my brain? So we need to be mindful of that, and it can overwhelm them. Some more challenges. So children with ADHD may struggle with verbalising their needs and emotions and their frustrations effectively, as I mentioned before. And they struggle with transitions from one activity to another. And especially if there's an ASD component and they really have interest in that set task, to move them off that set task can actually cause a bit of a meltdown. Here's just a few mental health stats for you that I want to throw in. So youth with ADHD are 25 more times likely to self-harm. That's massive. Researchers found females with ADHD are 2.5 times more likely than their neurotypical peers to engage in non-suicidal and 3 to 4 times more likely to attempt suicide. So again, we're looking at higher numbers. And understanding that underlying factor can impact a person's behaviour can help to develop strategies to better manage it. And again, I refer to it as scaffolding. It's putting those strategies around to how they manage their emotional meltdowns. But we need to teach that. We can't just give medication, and I say that with depression, I say that with most things. So you can give medication, but you need to deal with the other aspects of the person. Medication's not just going to fix it all. You've got to teach people how to manage this. And I also say neurodiversity is a superpower. So management strategies, it's about teaching, routine and structure, the visual aids, encourage physical activities because we know that helps. We know the research on exercise with dopamine. Positive reinforcement, effective communication. You have to be empathetic and you have to respect the personal space, using non-threatening verbals and avoid overreacting. Very hard to do in the ED, I would say. So my strategies I look at is to focus on the feelings, ignore the challenging questions, setting limits and choose wisely what you insist upon. Choose what you battle over. You can't battle over everything. Mark?
When you say ignore challenging questions, what does that mean?
Sometimes, I might be called out and the child's lost the plot a bit, they've had to stop doing what they're doing, they didn't want to do it, and they will start asking challenging questions back to the parent or back to get a response. So it's to shift it off the focus from them, and especially when we look at more of that PDA stuff that comes forth. So they're wanting to seek that autonomy and they'll do anything to try and get that. Allow silence to reflect and allow time to make decisions. People with neurodiversity can't just quickly jump to a decision. You've got to give them time. And I would say that with treat everybody like that. If they don't answer straight away, you've got to look at why that is. People need a bit of time, especially the neurodiverse community, just to digest it a bit. Dopamine. Do we know much about dopamine? Well, I say absolutely. So somebody, because drinking an alcohol drink might give you a bit of dopamine. What was that, sorry? Okay, yep. Yeah, so dopamine, in ADHD brains, it's lower. We know that. Research shows us that. So what a person with neurodiversity will do is they're trying to seek out that dopamine hit. That's the body's response. It's trying to give themselves that dopamine hit. And if we don't, as I said earlier, if we don't intervene early, then that's when people are more likely to do those risk-taking behaviours, start using substances, or start doing really risky behaviours to get that. We get bored easily. We jump from one thing to another. We can't really settle on one thing. We know the stats with, divorce in the neurodiverse community. It's high. Until it's treated, we see people often will separate, and it's because of the neurodiversity and the partner not having any acknowledgement of the brain or how that works. I had a partner once used to say to me, "Oh my God, I can't keep up." I go, "Well, I'm not keeping up. I don't know why you can't keep up with my conversation, but I've jumped from 3 topics. I know what I'm talking about. It's not my fault that you can't keep up with me." And I think the one thing we have to advise around those healthy dopamine hits. So, sorry, Susie, if you can write down some, because these guys are going to call out what's some healthy dopamine hits, and you've all been doing it. Snowboarding, exercise, absolutely. You haven't picked up your drinks, absolutely. Anything else? What else gives us a dopamine hit? Sex? Sexercise. Oh, exercise. Sexercise. I'm not sure what sexercise is. I'm thinking you're talking about sex. I don't know. But sex does give you a dopamine hit, absolutely. Exercise, okay.
But sometimes it can be a risky activity.
Absolutely.
That was the urological penis break before, so...
Yes, you need to be mindful how we undertake that exercise. Some simple ones: listening to music, taking a shower, being around people. That way we're not going to start looking for those unhealthy dopamine hits. But I did say absolutely twice and nobody's raised their glass. Bit disappointed, guys. Of note, I did do a talk recently around 10 minutes left, substance use. So I'm not encouraging everybody to get intoxicated. ASD, I'll quickly go through a lot of these. It's complex developmental disorder, impacts on the ability to communicate, interact socially. Do we have a good idea about ASD? Do you think I could flick through a couple of these quickly? I also have lots of handouts, so you can always come and grab some handouts that I think would be useful to have. So ASD occurs in a broad continuum. Some people with ASD experience only mild challenges. For others, the condition interferes with everyday life. And as it showed before, ASD definitely overlaps, I think, with ADHD. And the art when assessing is pulling it all apart. So I do have this on a handout, I think. I like to look at this because it's a different way of thinking about things. So thinking, creative, thinks outside the box, need to know how things work. I'll jump down. Moving, for some not at all. There's particular mannerisms that signify autism, like toe walking, a different gait, motor clumsiness, messy handwriting. Empathising, often overwhelmed by other people's emotions. People with ASD mimic. That's how they learn. If you overwhelm them, they will agree with you because it's too hard to actually ask you to clarify. So let's change our understanding, and I'll just again name a few of these. So instead of have the old attitude, I have high-functioning autism, I'm weird and defective, I'm a neurodiverse person with many personality strengths and abilities. That person with high-functioning autism is weird, he sits alone in the lunchroom and never socialises. Autistic people are often exhausted rather than energised by socialising. He's taking a much-needed rest. We need to think of that, and we need to reframe from the negative, how we perceive it, into the positive. So ASD symptoms and the deficit. Again, I know I've only got 10 minutes and I did want to get to some case studies, so I might whip through some of these. So if you just want to have a quick read rather than me reading. But again, I think you've got access to the slides too, don't you? Okay. Adult ASD. We have challenges taking turns in conversations. We might monopolise conversations with our own interests or thoughts unless we learn the strategies. One thing I learned very early on is if I'm in a meeting and I want to say to somebody, you are absolutely wrong, this is crap, I will doodle. So if anybody sees me drawing on my little pad, doodling, it means I really want to tell somebody what I think. But I know I can't, because that would be being really impulsive. Tips and reminders. So the best two interventions for autism and knowledge are our attitude. We need to change our attitude. Autism is a spectrum. I say it's at least 8 dimensions. It's not linear. And it goes from low to high functioning, which we all know on the spectrum. So we can go from low to high functioning. Does everybody have an understanding of that? And in its own, it's it's not a disability. And most autistic people refer autism first language or the term neurodiverse. I do have this handout, and I think everybody should take it. So it's 10 points to remember when talking to a person with ADSD, and I think it's important for everybody. If we use it with everybody, then it's effective. Yeah. So students with ASD, they don't have to look at you all the time. They find looking and listening a really hard thing to do. Give them time to answer any of your questions. They're slower processing. Sometimes it can take them up to a minute to formulate the answer in the correct sequence. Otherwise, they would just answer yes. So I say to my staff, when they're on the phone, they're rabbiting on with this long conversation, and I'm just wondering, you're still suicidal because when you spoke to the clinician the other day, you said you were suicidal because of the marriage breakup. How many, questions have we put to that person? They can't understand any of that. They hear the front bit, blah, 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 and the end bit, yeah? I'll just go through that. Another really busy slide, and I do like this one, because as I said before, I think neurodiversity is a superpower. There's giftedness in it. And they all overlap with the autism, ADHD and giftedness. And it's a really good thing to remember. People with neurodiversity aren't dumb. They're very, very smart. And in fact, as I said earlier, lots of people in our field are neurodiverse. And we do a damn good job at what we do because we're focused on it. Yeah? I say that because I want to know I've got a superpower. Another just a stat one, so we'll whiz through that. I've got this handout for you, and I know I've only got a couple of minutes, so I really want to get to some case studies, but a bit about trauma. So trauma, as I said, does overlap, and we need to be mindful because we might think it's neurodiverse, but there's actually a trauma history that we need to take into account. And again, we need to pull it all apart. And it takes time. It's not something you're going to get in half an hour. But if you know there's a trauma history, take that into account. A bit of confusion with the overlap. So intrusive thoughts, memories or other reminders of trauma may make children feel confused, agitated and nervous, which may mimic impulsivity and aggression. In response to trauma, a child's developing brain can become programmed to look out for behaviour and activities or events they perceive as threatening, and they become hypervigilant. What may appear as inattention and daydreaming behaviour, often seen in ADHD, may actually be symptoms of dissociation. Okay, I might whiz past that one. It's actually interesting, you could do a whole talk on trauma and neurodiversity. So I'm just going to give a couple of case studies. So this is a gentleman I'll call LW, so Luke. And he's 22 years of age. He's got different diagnoses from, he does have a trauma history, periods of dissociation due to that trauma history. When unwell, he'll go by a different surname. He also has ASD, ADHD, and periods of catatonia when he's overwhelmed. Triggers for him is new people in the house, parents returning from a trip, or heightened environments. And when I first met Luke, he was engaging in high risk-taking behaviour. He'd climbed a high crane on one occasion. He'd walked on the middle of the M1 on the concrete pillar. He tried to jump off a bridge, to the fact that I pulled him off the bridge. He was quite cute. He said to me, "I wouldn't have died, Kim, because I have a rope down my pants." But when he's catatonic, he hears everything. So often there's conversations that we have, as I mentioned, I think when Mark did his talk, we need to be mindful of what we say, that our patients do hear us. He will often blink when he's in a catatonic state, so he can hear you once for yes, 2 for no, 3 for I don't know. And tips for treating him is simple. Like, instead of come here, I always say follow my feet. So on that occasion I pulled him off the bridge. Another occasion we have Springbrook in the Gold Coast, beautiful national park. And there was a fatality up there right near where he lives. The sirens, there was police, and QS were called because police found him laying on the middle of the road in the dark. Because I knew him, I went up there. Before I got up there, unfortunately, QAS didn't know how to manage him effectively like we do, and he ran off into the national park. It was the most steepest part, and how he didn't harm himself, I have no idea. So we're in the process of calling out the police dogs to try and search for him, when all of a sudden he appeared, holding his ears. He was able to walk to me. When I said, "It's Kim, follow my feet," he then collapsed onto the ground in a catatonic state. We were then able to put him in the ambulance, and he loves jazz. Jazz often brings him out of it. So Luke and I sat in the ambulance listening to jazz until I would say, "Are you Luke with the W last name or the K last name?" And once I know it's a W, he's safe. So we tend not to bring him into ED in any of those occasions. And I suppose it's okay because I take the risk for mental health, whereas QAS would normally bring him in, and again, it's really traumatising for him. This is one I did recently. So we were called to a 17-year-old male. So the mother had contacted the Child and Youth Mental Health Service. He'd had one previous contact in December, but he refused to engage for very similar presentation. So he'd previously been linked with a private psychiatrist and diagnosed with performance demand avoidance, ADHD, ASD, depression, anxiety. He tried 2 schools, failed, homeschooled, failed at that. He hadn't eaten or drank anything in 8 days. So my alerts were, this guy's going to be really medically compromised, and I was concerned. He was sucking a chubba chup occasionally because he looked it up on TikTok. Okay. And he was storing his urine in a jar. So my mental health perspective was going, it's a bit odd. Like, is there a psychotic process behind this boy? He was refusing to come out of his room, and when his parents tried to get him to eat or drink, he threatened to kill himself each and every time. And they felt so, I did say the word manipulated, and he adjusted me on that terminology. They felt too scared to push the issue with him. So physically, he was extremely pale. He was thin. His hair was all matted. He was refusing to engage and asked his mother to send us away. When that happens, I just ask the parent to step aside, and I just try to engage the child, which he did eventually engage with me. However, he did occasionally keep walking into the walk-in robe that was closed in the dark, and I'd go in and try and engage him again. So my role then was, I thought there was a large component of mental health, but I wasn't going to push this kid. I wanted to engage him, and I wanted to get him to the ED because I felt he was really physically compromised. So sinus tachycardia with inverted T waves, and then continued to persistent tachycardia, which Mark mentioned in his talk. His BP was 142 on 92 standing, and after 2 minutes, only, had that postural tachycardia, but only by 20 points. But it's still, I thought he was really compromised. Oh. So these are his bloods. So when I first took him to ED, and the triage nurse, and often the neurodiverse don't get treated all that well, said, "Why are you bringing him in, Kim? He can walk and talk." I said, "Because he's really physically, I'm concerned he's physically compromised. He's neurodiverse. He's not going to cope in a heightened environment. Can we please get some bloods done and get him to a quiet area?" So that was the bloods that came up. So are they concerning to all the medical team there? Yeah. So he's now been in hospital medically for 12 days. And the latest impression by our CL psychiatry team is acute on chronic malnutrition for complex etiology. Middle adolescent with long-standing sensory and communication challenges, possibly autism spectrum disorder, likely neurodiverse. Long-standing restricted eating with quite limited food options. And again, in ASD you see that. The ASD will often have problems with texture of foods, or they'll be quite, they'll have their set routines about how they eat or what they'll eat. And he had eating disorder cognitions. He had recent withdrawal, meaning he just didn't want to come out of that room. Like when I got to him, he was in that room for 8 days. He had suicidal thoughts with intent, likely a low mood and anxiety. And the suicidal intent behind the acute food refusal was prior to admission, as per collateral that the parents gave. It's actually interesting because when he was sitting in there, we don't have your normal Bravo ambulance. We have a little, it's like a, van with a seat. And I often will type some notes while I'm talking to the patients to get things ready for ED. And all of a sudden he appeared behind me and he said, "I don't like your words." So I was typing. I said, "What word don't you like?" He said, "You called me manipulative." And I said, "I'm sorry about that. What word would you prefer?" And he said, I'm trying to think of it. "I tried to convince my mother." I said, "That's fine. We can change the terminology to trying to convince your mother." So he had ongoing deterioration in his mental state, likely with suicidal thoughts, likely complicated by his malnutrition. So again, mental health assessment shouldn't happen at this point because we need to make sure he's medically fit for us to do a mental health assessment, because otherwise we're confusing it with the physical symptoms. Possible depressive illness with long-standing issues with anxiety, ongoing suicide ideation. He was quite guarded still, ongoing challenges. He kept pulling out his NGT. And the parents refused for the medical team to keep putting it in because, again, remember his PDA and he's very convincing with his parents. They just said, "No, we'll try another way," because he doesn't want that. So which moves us into our aims that we have at the Gold Coast. So we're building the new Coomera Hospital, which is going to be bigger than, I think, what we are at Gold Coast. Is that right, Susie? It's going to be a bigger hospital. Okay, but we are planning a designated area for the neurodiverse, because we know bringing them into the heightened environment in ED is really, it's traumatising. We're doing ongoing education to staff around neurodiversity. I think everybody should be, up to date with what neurodiversity is. It's a popular topic of conversation, and I think it's got some bad points around, people saying somebody's just going to get an assessment for a stimulant, and there are people that do that. So we need to educate, and we're improving our communication awareness with our staff. Last slide, Quinton, I promise. And our key points. Communication is the key. Short, concise. Check context before moving on. It's like me with my accident today on the snowmobile. So it was so confusing. This is how you start it. Pull that red button up, then press the orange button, put your feet into the thing to hold your feet. This will stop the engine when you fall off. And there were so many instructions, wasn't there, Susie? I was like, I just know start and stop. That's all I need to know. And low stimuli areas if we need to bring to ED. Promise, I've only got a few. So I have an awesome team behind me. So I want to acknowledge firstly my daughter, who's the first slide. So I often drag her with me. She's a CNC in ED and I make her present alongside me. Second, we have our beautiful Peace and Airy. So without these two, they book everything for us. Area even got us a complimentary upgrade to the 3-story penthouse over at the Western. So thank you, Airy. And then we have Bucko. Where's Bucko? Bucko's our num of governance. And then we've got our whole Gold Coast team that's here to support us. So without our team supporting us, you know, I think that's really important. Yeah. Any questions? Mark?
Firstly, thank you. That was excellent. I want to get all these handouts you've spoken about. A lot of, in the sort of the neurodiverse and mental health field, medical terms often take on such meaning that they become stigmatising, and borderline personality disorder is probably one of the most stigmatising labels we can give to
Absolutely.
patients. There was a push a few years ago to sort of try and relabel BPD as trauma survivor.
Yes.
How do you think we could sort of try and not restart that process, but because the whole point of them, they make us, they displace a lot of their anxiety by making us dislike them. It's a compulsive thing, and we take it on and we reflect it back, and then suddenly the whole thing gets on. But it is a trauma surviving mechanism, or
Yep.
a mal-mechanism, shall we say. Is there a way that we can sort of move forward where if we go, oh, that patient is BPD, fine. Is there a way that we can sort of label it that the communication instantly among staff is more understanding of
Mm-hmm.
the fact that these young people, they didn't do this to themselves. There's almost always someone who's kind of stuffed them up for them.
Absolutely.
Is there a way, do you think we could label it that instantly we have more, a little bit more openness of our mind? Like, so you can't label on a trauma survivor, but is there another way forward where we can try and move the term BPD something more constructive?
I think you're right. I think there's a real stigma with BPD, and I think once somebody's labelled with it, it carries on. And I hate it when I see people come in and I'll get told they just need a therapeutic wait. They are distressed. Why are we making them wait? That's not going to help. If I'm distressed and you make me wait, that's not going to help me. I'm going to become more distressed. I actually did a talk in Bali which was on trauma, and I think we did a lot on that, which I'm thinking we may actually do in Thailand, but I need to have a better thought around the management, because there's been research done, and I think it was UK, I can't remember the research. It was done on the middle class, and it was an accidental research because it was a research around obesity, and then they found all these people had trauma. Yeah. And so what they say is people with 6 adverse childhood events, and that could be anything from divorce of parents, a parent with a mental illness, a parent goes to jail, like there's so many trauma. It doesn't have to be like this catastrophic like end of life thing. It puts them at, I think it was 4,000 to 5,000% more likely to commit suicide. And why the policies aren't looking at that amazes me. You know, we get our ruffles up when we go, there's 10% more risk of prostate cancer. And, you know, we do something, but we know trauma is huge. We know it impacts, as I said before, it affects our amygdala and our hippocampus. But I agree, we need to do more communication and education to our staff around management of trauma and not labelling. Because I often bung on about the overshadowing with mental health. So I think once they just see a label, they don't look at the medical side. And that was my thing with the young boy. I brought him in and was, what are you doing, Kim? Like, he can walk and talk. Like, we don't want a mental health patient in here like that. You know, so already there was a stigma attached because I brought him in. And it's just lucky because I have really good communication with the ED, so I will go straight to a consultant because we have that good rapport. Or I'll ring Susie, say, hey, I'm coming in, I've got this 17-year-old, I really want a low stimuli environment. You know, we need to be mindful of the trauma behind him. He's neurodiverse, like what can we do? But I'm not sure if I've answered your question, but I think it's about education and changing the labelling and not labelling so quickly. Yeah?
I've got a question around facilities. In South Australia, we've got lots of problems with ramping, and we
Yep.
are exploring all sorts of ways of reducing this. But the one thing that I find is one of the most difficult conversations with the hospital administrators and the development teams is around this waiting room is not suitable. Is there a set of guidelines how to cater better for neurodiverse people that we can refer back to? We always get this, give me a reference, give me a resource, you know, just because you're saying this or because our consumer advisors recommend this, that doesn't mean that you need that. There's wants and needs. And I really would love to see somewhere just a guideline saying, you know, simple things like access to natural light,
Yep.
less noisy environments, not having, you know, a massive waiting room with 100 people,
Yep.
bright lights, like that little stuff
I would need to have a look back on that. When I did a brief review, I didn't see a lot, and I think it's becoming more prominent because it's becoming more acknowledged. So I think back when I was young, neurodiversity was a like taboo, it was stigma, like, oh, you weren't going to take your child to be assessed because you were just deemed as being not a functional parent if your child had neurodiversity. I know we've acknowledged it in the hospital, and that's why we're trying to find, our new room at the new hospital. Part of our role is keeping people out. So it would have to be a really good reason for me to bring a neurodiverse person into ED. And I get really frustrated, I think, at the moment with NDIS. I hope nobody is from NDIS here. But, we're often called to our SILs, our supported independent living, and the workers go, I'm not allowed to do anything. What do you mean you're not allowed to do anything? Like, where's your behaviour support plan? Oh, we don't have one yet. Or it is just not relevant. I have a guy I go to all the time, and he's quite low in IQ. He desperately wants to see his parents. He loves me because my name's Kim and so's his mother's. He's becoming more aggressive and he's assaulting more and more staff. So their role is they run. They run and they jump the back fence if they need to run because he will smash that house apart. So we will often go there, just try and review and keep him because bringing him into the ED is not the answer. I can hold that risk, but I acknowledge that most paramedics can't hold that risk.
Unfortunately, we're going to have to call the questions there. Can we have a big round of applause for Kim and Kim for helping?
Okay. So I'm just going to, if you want to take a photo of this, sorry guys, it's just resources I often give families because families want something. Families want to know what they can do for their loved ones. So if you want to take a photo of that, I think you'll find it really useful to look those up. But thank you for having us yet again.
Thanks, Kim. And we do have the handouts that Kim was speaking about at the front here, and also all these presentations are being recorded, and in that info book that we have, the links are on there if you want to have a closer look at some of those slides. Let's just take 5 minutes. This will probably be our last break as well. So 5 minutes, and then we'll get cracking after that.
Oh yeah, is that okay?